Hello, doctor, and good morning. So for today, we wanted to discuss about Medicare Advantage and how do you think it is changing? We wanted to talk about the big changes that are coming up, any disruptive trends that you've noticed or any good ones, and how the end of 2024, start of 2025 will look like.
Great question, and so much to talk about there. I think one of the good things that's come out of a lot of the recent changes is that folks are recognizing how important it is to see patients often and early, to make sure that they're documenting comprehensively, and that they're attending to those quality gaps. And so I definitely have seen a greater sense of urgency, and more emphasis, right, and focus on getting documentation right, getting patients in, seeing them, et cetera, et cetera. So all the things that are important with value-based care, including a greater attention to now on total cost of care, making sure that, the right procedures are done at the right locations that are cost effective, but still effective and care for patients, as well as letting patients know where urgent cares are, as opposed to, say, going to the emergency room when they, need service, or getting in to see their PCP. So I've seen, I think, lots of movement and improvement around quality of care. Not that the care that our physicians were doing before wasn't phenomenal. It was, but I think just the documentation and the things that are needed so that they could be reimbursed appropriately, and then those monies provided back into the system. With that said, things that I want to caution folks to pay attention to, it's almost the same thing. We're coming up on September sweeps. It's super important that you're getting your data in. You want to make sure that you have the last 6 months of 23 and the first 6 months of 24 submitted for those September sweep deadlines. If you're a risk-bearing provider group, your deadlines are probably about now, or at least within the next couple of weeks, though your health plan payer partners will usually take that data all the way up until the end. You don't want to risk it and wait, but you want to get your data out there. And the reason why I say this is, you have the influence now of V28 and V24 coming together. And so you would have experienced some of the effects in the payments that you just received or are about to receive this summer, but it will definitely impact to a greater extent in January. And so those that did a great job of capturing, say, asymptomatic PAD or some of the other conditions that were part of the V24 model, they're going to be, they're starting to be phased out as we take more and more on with V28. And so that's something that you want to think about. And so it's an imperative, right, to have the most comprehensive data submitted in time for those September sweeps. And then again, doing everything you can to make good on 24 so that you also then have a good submission period. You'll be submitting 23 in January, but knowing that 24 is closely behind with March sweeps in 2025, you're going to want to make sure that you're doing everything you can around that stewardship of the data. Other trends that I've seen, I know that there's a lot of concern around privacy. And so really thinking about the partners that you're partnering with. Are they HITRUST certified? What are they doing to protect the data? I know I have a lot of clients requesting onshore services versus offshore. We also know that there's an attention to not only having codes listed, say, from a chart review or a home visit, but making sure, again, that those patients are getting seen more regularly by their provider. And we should see evidence of care in the record. If someone's a diabetic, we should see that progression, right, and their care documented throughout the record. And if it's not, then it could potentially be suspect. So those would be the things that I would say are going well because of the changes. And then the things, those are the same things that I think we need to keep on in order to be successful as we move from 24 into 25, at least related to value-based care. There were a lot of changes around the sales cycle, marketing materials, what brokers can do, around, extrapolation. So lots and lots of updates, lots of new programs out by CMS this past year. But if I were looking as a risk-bearing provider group or say a health plan that's engaged, in a risk arrangement, or in risk arrangements, those would be the things that I would attend to.
So, doctor, you mentioned about V24 to V28. So, what do you think is the best strategy for the healthcare organizations and payers to shift easily from V24 to V28, especially and particularly in terms of risk
Um,
adjustment? Sorry.
Yes. And again, great question and lots of things to consider. So one, I'm a believer in always taking snapshots of your data. If you're not doing that regularly, you need to make sure that you're doing that. You want to make sure too that you're calculating your risk score not only in V24 but in V28 so that you're fully aware of what the expectations might be and the implications might be for your finances. The other thing that I would say is, again, making sure to get your patients in. So using, if you're a risk-bearing provider group, and if you're a health plan, working with your risk-bearing provider groups, and if you're a health plan doing this work, working with your customer service teams, reaching out to patients, making sure that they're getting in to see their physicians, getting that holistic visit. I think great education programs around documentation is important. I think we need to get away from the annual wellness and trying to capture the alpha and omega on that patient. It's taxing for our doctors, and I think that we can still get the same value, um, at least, the appropriate remuneration if we are encouraging physicians to see their patients frequently and then documenting what it is that is relevant or significant that they're attending to in the visit. The other thing I would say, so in addition to taking snapshots of data, in addition to seeing your patients, the other thing that's going to be key is focusing on total cost of care. And so, what programs can you put in place to help manage those costs? And things might be, if you should be making sure that patients have a place to go after hours. Is there an after hour service at their physician or, your primary care physicians? Or if you're a primary care physician in a risk-bearing relationship, do you all the patients know where they can go for an urgent care? One of the things that I've been a part of in the past, different campaigns, was taking a look at patients that went to the emergency room that maybe, the diagnosis or the things that came across on the claim, there were opportunities to have them either be seen, and treated through an aftercare or after hours nurse line, or maybe they could have gone to an urgent care or even using your home visit vendors, right? There may be an opportunity there. It's much less to do, say, even an after hours telehealth visit or to have someone go out into the home and do a home assessment, provided that they can treat. I know that there are some nuances there that one would have to work through, but those could potentially be opportunities to save money. Equipping your primary care offices to do certain procedures that would be appropriate there, as opposed to requiring them to get a referral to a specialist. And I think, really looking at network adequacy, and that your network is built in a way so that patients can get adequate access to care will be super important. You said in specific to risk adjustment, and of course, seeing patients and making sure to capture everything that's relevant to them will be super important. But I think one of the things that we need to notice is that risk adjustment isn't enough any longer. And so you have to be really good at risk adjustment, but you also have to make sure that you're doing a great job at quality and that you're also doing a great job at your total cost of care programs, because the reimbursement from V28 is not going to be the same as it was, say, for V24. Um, I think for V28, just specifically with risk adjustment, having complete data, making sure those patients are being seen and being seen many times throughout the year, as is indicated by their chronic conditions, making sure to, to document all that information. And then equally important is making sure to submit that data on a timely basis. And ideally, your claims are being processed timely, they're comprehensive and complete. They include all the data that's relevant for that patient, so that that's being consumed. And then your reimbursements that you're getting throughout the year are appropriate. I think one of the other things that folks should take a look at is doing concurrent review. Again, it goes to that timeliness. And so if you have the ability to do either some pre-visit planning, looking at the charts before the patient's coming in so that you are attuned to what chronic conditions might need to be redocumented. Because again, everybody becomes healthy in risk adjustment, at least Medicare risk adjustment on January 1st. And so you want to make sure that you're recapturing all those conditions. So doing some pre-visit planning, then I would say concurrent review. So as the physician is in the office seeing the patient, there may be opportunities to insert a scribe, use AI, have a coder as part of that process that can review the notes, is working with the physician to make sure that any diagnosis that is given during the visit is documented appropriately so that it's substantiated in the medical record. And then, of course, afterwards, making sure that everything, I think that there's a real opportunity to connect what's going on with billing, and then also with risk adjustment coding, because billing coding and risk adjustment coding are two different things. And so there's opportunity there to make sure that the bill is comprehensive and complete. And so I think that there's an opportunity to look at how you might improve the intersection of those functions so that when the claim or encounter gets reported, that it has all the relevant data that's important, not just from a billing standpoint, but also from a risk and quality capture standpoint, and that it's being processed appropriately. And so then the next step would be, you have to finish that entire loop. And so looking at the data, making sure that if you're a risk-bearing provider group, the data's made it to the health plan. If you're a health plan, the data's made it to CMS. If you're a risk-bearing provider in an ACO, that the data's made it to CMS. And then CMS gives you those return files. And so that you're double checking and making sure that everything that you've submitted on that patient has actually been captured. It's like I always liken it to an exercise, an operator. If you remember that, as a child, you would pass a message on down the line. Very similar with healthcare data. We never know where things might fall out and leak out. And so you always want to be looking to make sure that all the hard work that you've done, that you're getting, you're getting that credit for it, and that it's making its way all the way through and being reported.
So I only have one more question left. So I know that we've already spoken about teams and other changes, for example, primary care flex and other models, but is there anyone that you think that will be very particularly important in 2025 and that organizations should start immediately looking at?
There's a lot of really great programs out there. I would say I would look at two things, and I don't know that I would call out a program in particular, but I'll call out elements of them that I think are really important. When you look at ahead and you look at teams, there's opportunity there, and I was talking before about how important I think total cost of care is going to become. And so if we look at those two models, one of the things working for a risk-bearing provider group and for a health plan, in my past, one of the things that we always noticed is that, it was challenging sometimes to do the work that we were doing because you didn't have the relationships with the hospitals and with the specialists. And so I think that these programs offer that opportunity. And so I'm really excited to see how we continue. You already see there's a lot of specialty groups that are focused on risk. We've seen a lot of work by our nephrology community. I know I've heard from our oncology community. So I think that, now even, orthopedics. And so I think we'll continue to see greater involvement by specialty, and then also with our hospitals. So when I think about the programs that are launched, it makes sense to me because I think that that was a true need. And then the other thing I would say, and what I liked about Primary Care Flex, is that it gives monies to the physicians and their offices to be able to put the infrastructure in place. Because one of the learnings, I think the biggest learnings from ACO Reach was that, there's all these great programs, but they didn't necessarily solve for some of the challenges that were there. And we know that interoperability and having, point of care suspecting or point of care information that the physicians can use to capture, for risk adjustment, so to capture the chronicity of the patient as well as close quality gaps is so important. So I would say, that those two strands are important, making sure that we have the infrastructure that supports interoperability and provides data real time is going to be important. And we see programs that are providing that. Primary Care Flex is providing a stipend in front of, at the beginning of the program for the physicians to use for the purpose, right, of getting those systems in place. Whether or not it's enough remains to be seen. But at least it's something, and it's a nod to or recognizing that that's necessary. And then the other piece is that, the healthcare system is kind of like an octopus, I guess you would say, with many tentacles, in that you have to consider if you really want value-based care to work, you have to consider the importance of specialty physicians and hospitals, to the work that the primary care physicians are doing. And so to the extent that you can bring them along in value-based care, I think is really important.
Great. Thank you so much, Doctor, for answering all of my questions. And one last thing that I wanted to talk about is that do you think that adopting AI is going to be really helpful in the next year or so?
I do. I think that there's so much information out there. It's important to find a way to be able to consume it and make sense of it. But here's the thing that I would caution. Know, who you're working with. Of late, I've seen a lot of AI that either has rules in it that someone who doesn't understand risk adjustment or quality or the work that we're doing, and so it doesn't always account for all the nuances that may exist. And so some of the things that I've seen with clients of mine that I'm working with is that they're using systems that have rules applied that might be stripping out information or not submitting information. I had one system that's automatically trumping out codes. And while CMS does that at a provider group, you don't want to do that. You want to submit every single code that's applicable for the patient. It's great if that diabetes is in under V28. This doesn't necessarily make a difference, but in V24, it still does. If it's diabetes versus diabetes with complications, I am working with a group that's using a system that the AI and the system that they're using, the platform is built on what they believe to be health plan requirements. And so this is a risk-bearing provider group. And unfortunately, the system is not very flexible to adjust for that. And so what's happening is that it's automatically trumping that lower code as it goes out to the health plan. And some of you may say, well, Shannon, that's what it does. And I say, that's well and good, but knowing what that data leaks out, things fall out, things get unconnected, it's better to send everything. Really, that trumping is the work of CMS. And so I think what we have in our industry is that you have folks well intended, they hear, pieces of information. They maybe don't have a full understanding of the industry or of, the clinical rules, if you will. And so they're applying things without having that full really 360 circumspect view of the healthcare system, of the risk adjustment program, of quality, and they're applying these rules. And what's happening, I think, is that they're getting ahead of themselves and they're potentially losing value. So I think AI is super important, We need a tool like that. But what I would say again is, this cautionary tale of make sure that who you're investing in and the AI that you're working with, don't think that, first of all, do your due diligence and make sure that you vet that organization well. And then the other thing I would say is, test it. Don't assume that it's a silver bullet. Don't assume that it's going to replace people. Like I said, we're using real people now to circumvent some of that trumping that's going on early on, because it is costing value to that particular provider group. And this platform, I think it's a great platform for a lot of reasons. But in this one instance, it is detrimental, and it's a well-used platform across the United States. And so unfortunately, I think that there are a lot of risk-bearing provider groups who could use that revenue that are missing out because they're using an AI tool that is not, you know, and I don't think it's a fault of the system. It's just not where it needs to be. And again, you have folks that are applying rules that in some ways can be injurious. And so again, you want to make sure that you're vetting things appropriately, make sure that your AI partner is doing the diligence that's necessary, and then that you too are doing the diligence and constantly checking and making sure that the AI is functioning in a way that's working for you. Because again, important with all that wealth of information, but you don't want to lose things that could be important, and then obviously could impact performance as well as payment related to that performance.
Thank you so much, doctor. So I guess at the end of the day, what the most important thing is choosing your vendor, the correct
Absolutely.
vendor.
Absolutely. Absolutely. And staying connected with them. So choosing them, but then making sure, in my mind, one of the things that I look for when I choose a vendor is someone who can be a true partner. If you have someone that discounts the people within your organization and says, hey, we have it, you don't have to worry about it, I would get very nervous about that. It's not that others, it's not that you don't trust your vendor. You obviously should trust your vendor if you're selecting them, but it should be a true partnership, and you should be able to have that dialogue. And again, risk adjustment, value-based care, quality is really challenging, and not everybody can be the source of truth, right? Or the full source of knowledge. I mean, I go out and I read, the different pages for CMS and HHS. And I think I shared one time on an earlier webinar that we did, or podcast, that I ended up back in 2011. And it can be somewhat of a rabbit hole. And so it can be very difficult to know those rules. And so I think it's really important that you are bringing people together from both organizations to have that dialogue and that conversation and recognize the choices that you're making. So, like, for example, if you're applying trumping logic at a provider group level on their submissions, that you understand what the repercussions are and that you don't dismiss the concerns that the provider group shares with you, because you're doing that work. And I think being forthright, right, in that those are the types of rules that you're applying. And then I would say, that's one example that I'm using from real life that I've experienced in the last few weeks. But making sure again that you're having that dialogue and that you're working together. And someone that's flexible. Some of these systems are built, and they're not built in a way that they can bend and apply rules that a particular group may need or have. And so, those would be things that I would use when you're doing your vetting, making sure that you include as part of your due diligence.
Thank you so much, doctor. So that concludes our session for today, but really great chat and really informative as well.
Awesome. Awesome. All right. Good.